I am part of the physician advisory board of Coaxial, which is the manufacturer of the NeuroFlow trial. And the NeuroFlow device is an investigational device in the United States. So the objective here is to discuss the issue that we just mentioned. The Flow 24 trial was a multi-center, single-arm trial in 9 academic centers throughout the United States and Europe to investigate the safety and feasibility of the NeuroFlow catheter in patients with DWI-PWI mismatch using the DS criteria within the 8 to 24-hour window. Here we describe the imaging findings and we explore some hypothetical associations between the collateral flow pattern and the treatment response. Just a brief review of the device. It's basically a dual balloon system where you have one balloon that is placed above the renal artery, another balloon that is placed below the renal artery, and you inflate this balloon to occlude approximately 70% of the aorta. And for mechanisms that have to be yet elucidated, you basically increase cerebral blood flow. It may be as simple as just shunting the blood from the higher resistance lower body to the lower resistance cerebral circulation. Brief review about the trial. It said multi-center international, single-arm, 9 academic medical centers look at safety and feasibility of NeuroFlow in patients aged 18 to 85 years old with a baseline inr6 score 4 to 20, who had a PWI mismatch greater than 20%. The treatment initiation had to start after 8 hours, but before 24 hours after last normal amount. There are some exclusion criteria, including patients who had a premorbid state higher than modified on a scale of 2, hypodensity or effacement of suicide greater than a third of them say territory, current or previous hemorrhage, including 5 or more microbleeds on susceptibility MRI, any use of thrombolytic or thrombectomy therapy, any intracranial lesions that are at risk of hemorrhage, high blood pressure as in previous trials, renal failure, abnormal hemostasis, as well as several cardiac and aortic issue, anatomy issues. Summary of the results: 26 patients were enrolled. Out of these, 25 were treated. 1 patient was excluded based on aortic morphology. The trial happened from May 2007 to September 2008. The median age of these patients was 60 years old. 44% were males. The median inr6 scale was 12. The median time from last seen to treatment was 14.2 hours. 48% of these patients reached a good functional outcome at 90 days. The mortality was 20%. There were 13 asymptomatic hemorrhages, of which only 1 was a PH1. There were no PH2s or symptomatic intracranial hemorrhages. The rest and favorable outcomes were inversely related to the baseline inr6 scale, but directly related to the time from symptoms discovered to treatment, which is a little bit counterintuitive, as you'd expect. Specifically, 76 of the patients, or 19 patients out of the 25, had a proximal arterial occlusion. Those are the patients that you can study here. So our main hypothesis was that treatment with NeuroFlow resulted in at least temporary stabilization of the ischemic penumbra due to a collateral flow augmentation effect. Meaning, patients would respond to these treatments would demonstrate a lower growth of the core tissue into the penumbra area as compared to treatment non-responders. We then further hypothesized that the ability to respond to treatment with a flow augmentation therapy relates to the vascular anatomy. Basically, if you don't have a direct collateral flow pathway to the brain, you're not going to respond to this treatment. Specifically, the patients that would fall in that category were patients with intracranial and or cervical ICA occlusions that did not have a functional ACON or PCON as visualized by the flow-related enhancement MRI in the ipsilateral cerebral hemisphere. Also, we thought that you had to have a stability of perfusion pressure after the treatment, and you'd be finding a stable pressure as a drop in pressure greater than 25% MAC baseline, or systolic blood pressure sustained less than 80 millimeters of mercury. The patients were then categorized according to the presence or absence of persistent occlusion on post-treatment angiogram. The idea here was to isolate the collateral flow effect. Of course, if the patient recanalized post-treatment, any improvement in flow would be just from antegrade reperfusion related to the revascularization. So you look specifically at the patients with persistent occlusion. And the measure of outcome that you focused was the DWI MRI imaging obtained within 4 hours after the treatment. So here is a quick summary of the results. Basically, there were 19 patients with proximal arterial occlusions. Out of these, 1 patient didn't have good imaging, so was excluded. Then you basically look at the post-treatment recanalization status. Out of these, 5 were recanalized, so they were not really the main target of our analysis. But out of curiosity, 3 of the recanalized patients had stable DWI at 4 hours, and 2 had progression of the DWI at 4 hours. The patients that actually had a persistent occlusion on the MRA, meaning there is a persistent occlusion, so if any stabilization effect would be related to collateral flow. They were 18 patients. And then you look at the 2 main criteria that you expect for a treatment response, meaning a favorable vascular anatomy for collateral recruitment and a stable perfusion pressure. So 8 patients fulfill this criteria, and out of these 8 patients, 100% had stable DWI at 4 hours post-treatment. Conversely, none of the 5 patients who did not fulfill both criteria had a stable DWI at 4 treatment. There was extension in all 5 of 100%. Here is basically a more detailed view of the results. You can see here in the shallow area, these are basically the patients who had a favorable response. And if you look at them, COW is no function circle of Willis. Decreased BP is basically unstable perfusion pressure, and all of them had 1 or 2 of these findings. Conversely, the patients who didn't have these issues were pretty stable at 4 hours. It is an example, basically, a patient that had an M1 occlusion. So there is actually a route for ACA and PCA collateral recruitment after neuroflow treatment, and that patient actually had a stable DWI at 5 hours post treatment. Another case here of an example of a favorable collateral recruitment profile, in a stable perfusion pressure in a collateral flow via the circle of Willis via the ACON. So you see a favorable collateral profile, and here you see that the DWI lesion is stable post-treatment. Conversely, this patient here had a favorable collateral recruitment profile, but had a drop in perfusion pressure. So you can see here occlusion of the ICA, but a great ACON, which would allow for leptomeningeal collateral flow to that ipsilateral hemisphere, and you can see given the drop in perfusion pressure, there was extension of the infarction. Final example is this gentleman had an unfavorable collateral recruitment profile, despite a stable perfusion pressure. Basically, you see lack of flow-related enhancement in the ipsilateral territory to the stroke, and then you can see this posterior evolution of the stroke. To conclude, there are limitations to the current study, mostly related to the small sample size and a lack of control group. Obviously, we all would expect that patients with good collateral flow and good perfusion pressure could just do well by their natural history. However, it helps backing up our current thought about the mechanism of action of the neuroflow system, which is this flow augmentation effect. And it also supports that improper selected patients treatment with the system appears to be safe and may result in at least temporary stabilization of the penumbra tissue, even at time windows as late as 8 to 24 hours. A favorable anatomic profile for recruitment of collateral flow and a stable post-treatment perfusion pressure appear to be essential factors in the response to flow augmentation strategies. Thank you very much.